550-2310. That is plus 251-94-550-2310. But we can also talk live and also take your questions through the question and answer section. Now, today we do have interpretation in French, so you can select the language of your choice from the line below on this platform. It is now time for us to hand over to Dr. which we will then go into the question and answer section. Dr. Ogwell, it's over to you.
Thank you. Thank you very much, Wayne. Good morning, good afternoon, good evening, wherever you're joining us from. The first day of September 2022, I would like to share with you updates on the health emergencies here on the continent, and we will start with COVID-19 situation here in Africa. To date, we have documented 12,044,535 cases of COVID-19 since the beginning of the pandemic, and this accounts for 3% of the total number of COVID cases globally. The recoveries, we have documented 11.4 million people, and this accounts for 95% of the cases that we have reported here in Africa. Unfortunately, we have lost 255,577 people, which gives us a cumulative case fatality rate here in Africa of 2.1%, and the deaths that we have documented accounts for 4.1% of the total number of deaths due to COVID-19 that have been reported globally. Looking at the burden of disease by country, the following 5 countries account for 61% of all the cases that have been reported on the continent of Africa. South Africa with 33%, Morocco 11%, Tunisia 9%, and Egypt and Libya each with 4% of the cases. When we look at this week, 41 countries are reporting a case fatality rate that is higher than the global average of 1.1%. So out of the 55 member states of the African Union, 41 are reporting case fatality rate that is higher than the global average. The same 2 countries, Somalia and Sudan, are still reporting a case fatality rate of higher than 5%. It is also important to note that no new countries have reported a 4th wave. And when we look at the 5th wave, again, no new countries have experienced that. The same goes for the 6th wave. The same 5 countries have experienced a 6th wave, and no new countries have experienced a 6th wave. When we look at the variants of concern, we see that there is no new change in the variants that have been reported so far here on the continent of Africa. When we look at the sub-lineages, one additional country, that is Sudan, is reporting Omicron BA2 sublineage, making the number of countries on the continent that are reporting this particular sublineage to be 30 in number. For the rest of the variants and sublineages, there is no change from what we shared during last week. And our teams across the continent, our reference laboratories, continue to monitor the situation of variants and sublineages through regular sequencing of samples. Looking at the 1-week analysis, epidemiological week 34, which is the 22nd to the 28th of August, when we are comparing with Epi week 33, the situation is as follows. New cases, we have documented a total of 7,167 new cases, which is a 9% decrease from AP week 33. Looking at these proportions by region, we see the northern region accounting for 32%, southern region 31%, western region 20%, eastern region 12%, and central region 5% of these 7,167 new cases that have been documented during AP week 34. When we look at numbers, the following 5 countries are reporting the highest numbers of the new cases during AP week 34. And these are South Africa with 1,627, Tunisia with 1,394, Nigeria 436, Morocco 331, Zambia 312. When we look at the data in terms of incidents per million population, the following countries are the top 5. Seychelles with 171 cases, new cases per million population. Tunisia, 16. Sao Tome and Principe, 11. Comoros, 8. And the Gambia, 6. During this same week, a total of 38 new deaths were reported in Africa, which is a 3% increase compared to AP week 33. When we look at the trend over the last 4 weeks, and that is from the 1st to the 28th of August 2022, the number of new cases, we saw an overall average decrease by 24% across Africa. And when we look at that same period by region, we see a 7% increase in Eastern region, 31% decrease in Central region, 29% decrease in the Northern region, 16% decrease in the Southern region, and a 3% decrease in the Western region for this 4-week period from the 1st to the 28th of August 2022. When we look at that data by the most populous countries on the continent, we see a 7% average increase in the DRC, a 6% increase in Nigeria, 18% decrease in Ethiopia, 16% decrease in Kenya, and 11% decrease in South Africa, while in Egypt, there was no significant change. The same period, when we look at the number of deaths, we see that we documented an average decrease of 12% in the number of new deaths on the continent during this 4-week period. When we look at it by region, 68% increase in the Southern Africa region. These are the number of new deaths during this 4-week period. 67% increase in Eastern Africa region, 18% increase in the Northern Africa region, 17% decrease in the Central Africa region, while 4% decrease in Western Africa region. The same number of deaths when we look at from the perspective of the most populous countries in Africa. South Africa, a 100% decrease, meaning there were no new deaths documented during the time. Kenya, the same, 100% decrease. The DRC, a 48% decrease. Ethiopia, 83% decrease, while Egypt and Nigeria, there was no change from the previous 4-week period. Let's look at the testing capacity and feedback from the continent. To date, we have over 122 million COVID tests having been done in Africa throughout the 55 member states since the pandemic started. Over 227,000 new tests were reported for the AP week 34, which is a 44% decrease from the previous week, when we had over 405,000 tests being reported during EP week 33. So during this EP week 34, the positivity rate is at an average of 3%, while the test per case ratio is at 32. This gives us an increase by 63% in the positivity rate and a decrease of 38% in the test per case ratio when we compare with the previous week. One member state is still reporting a test positivity rate that is higher than 12% during AP week 34. In vaccinations for COVID-19, to date, 945 million COVID-19 vaccine doses have been supplied to the African continent. When we look at the total number of doses that have been administered, we see we stand at 677 million, which corresponds with 71% of the total supply of COVID-19 vaccines on the continent. Our coverage is 22.1% of the total population being fully vaccinated, while 2.7% have been boosted. When we look at the trend in the number of countries, the top 10 of our member states that have vaccinated more than 40% of their total population, we see that Seychelles has increased over the last 1 week to be at 81.5%. Rwanda has increased to be at 76.9%, and Sao Tome and Principe has also increased to be at 44.9%, but the top 10 countries remain the same as we saw during last week's briefing. In terms of supply, under the AVAT initiative, as at the 30th of August, 81,413,500 Johnson & Johnson doses had been delivered to 35 Africa Union member states. And the division of these 35 countries, what these 35 countries have received of the 81 million doses is as follows. 56 million came through the Africa Union mechanism, where member states themselves have purchased these COVID-19 doses. 17.9 million was through the Saving Lives and Livelihoods initiative, supported by MasterCard Foundation, to purchase these 17.9 million doses of COVID-19 vaccines, while the US government has supported this initiative through AVAT by 7.3 million doses of COVID-19 vaccines. It is important to note here that we continue to deliver new vaccine doses to member states as we expand the vaccination process within countries through the Saving Lives and Livelihoods initiative that is currently underway in many of these countries. And to give you just a little bit of detail in terms of where we are with the Saving Lives and Livelihoods initiative, one is to confirm that currently MasterCard Foundation remains our biggest partner in the Saving Lives and Livelihoods initiative, but we have others who have come on board and are supporting this particular initiative, including the Rockefeller Foundation, the Packard Foundation, the AFD of France, that's their development arm, as well as the Bill and Melinda Gates Foundation, and KOICA from the Republic of Korea are contributing to expanding the Saving Lives and Livelihoods initiative as we aim for reaching 70% of Africa's population being fully vaccinated. So under the Saving Lives and Livelihoods initiative, as of this week, 49 of our 55 member states are participating. We have initiated activities with 49 of our member states. 37 have their plans completed and approved, and we are going through the stages now of starting implementation. Out of these 37, 6 are currently undergoing active implementation, and these include Ethiopia, Kenya, Lesotho, Namibia, Nigeria, and Rwanda. Within this week, we are going to launch in 4 more countries, and that is Comoros, the DRC, Tanzania, and Uganda. By the end of this month, we will have added an additional 7 countries, being Burkina Faso, Djibouti, Gabon, Malawi, Sierra Leone, Togo, and Zambia. It is important to note that these launches at country level are giving us very good feedback, because we see the number of doses within those countries that are participating, the number of doses being used up is increasing, the number of the population that are being fully vaccinated is also increasing, and as we onboard more and more countries, we look forward to that 20.1% increasing to a more decent number, closer and closer to our target of 70. Now let's look at other public health threats on the continent. Today, I would like to share with you 8 significant outbreaks that we are currently dealing with on the continent of Africa. You will see that the numbers have increased. Significant ones were 5 last week, and now we have 8. Let me start with monkeypox. Since the last briefing, we have on the continent of Africa documented 656 new cases, including 24 that are confirmed and 632 that are suspected. And unfortunately, we have also documented 19, that is 19 new deaths, giving us a case fatality rate for this week of 2.9%. The countries affected during this past week include the DRC, Morocco, Nigeria, and South Africa. However, the numbers, the new cases, when compared to the previous week, we are seeing a 50% decrease in the number of new confirmed cases, and we are looking forward to that decrease being sustained over the coming weeks. During this last week, the countries that are reporting new cases of monkeypox, DRC has reported 558 new suspected cases and 17 new deaths. Morocco, 2 new confirmed cases, but no deaths. Nigeria, 95 new cases, including 21 that are confirmed, and 74 that are suspected. They have also documented 2 new deaths, giving us a case fatality rate of 2.1% during that period, while South Africa has also documented 1 new confirmed case and no deaths. Cumulatively, therefore, from the beginning of this year, 2022, we have documented 4,107 cases of monkeypox, which includes 483 confirmed and 3,624 suspected cases, 124 deaths, giving us a cumulative case fatality rate of 3% in 11 of our member states here in Africa. In terms of support, we continue to provide capacity building, test kits, and clinical management training to all the affected member states, and we continue to work with within our international systems to secure more laboratory test kits, as well as discussions on vaccines continues, but none has yet to come to Africa. The second outbreak I would like to share is wild polio here on the continent. In the previous week, we saw last week that 1 new case and no deaths of wild polio type 1 was reported in Mozambique. And when we look at the cumulative numbers since the beginning of this new outbreak of wild polio here in Africa, we now have 6 confirmed cases of wild polio type 1, and no deaths have been reported from the 2 member states that are reporting the 6 cases, and that is Malawi reporting 1 and Mozambique reporting 5 cases so far. We are working with both governments of Mozambique and Malawi to expand vaccination throughout the affected areas so as to limit the possibilities of spillover infection as a result of wild polio type 1. We continue to build capacity as well across the continent for their affected countries as well as their neighbors, so that our surveillance mechanism is working well, and also our clinical management is optimal. The third outbreak I would like to share today is Ebola virus disease in the DRC. Since the last brief, no new cases and no new deaths of Ebola virus disease have been reported from the DRC. And cumulatively, we still have that 1 confirmed case and that 1 death, which resulted in death, that was reported from the Beni district in North Kivu province of the DRC. No new cases. After this 1 case was identified and died, there's no new case that has been reported. We have deployed our experts to North Kivu province in collaboration with the government of the DRC, and we continue to provide support in trying to understand how the cycles are actually being facilitated, where the reservoir may be, and this will enable us to understand the new outbreak and therefore help us to prepare better and prevent future outbreaks of Ebola virus disease. The third outbreak is a multi-country yellow fever outbreak. Since the last time that we spoke about yellow fever, Cameroon and Central African Republic have reported cases of yellow fever as follows. Cameroon has reported 7 confirmed cases, but no deaths, while the Central African Republic has reported 9 confirmed cases and no deaths. Cumulatively, therefore, 33 confirmed cases and no deaths have been reported from Cameroon and the Central African Republic from the beginning of the latest outbreak of yellow fever here on the continent. We are supporting both CAR, that is Central African Republic, and Cameroon in conducting vaccination campaigns in the affected areas so as to limit the possibility of serious illness and death amongst those populations. We are recommending to our member states to leverage the systems and the infrastructure we've been using for COVID-19 to reach the affected populations and provide them with the necessary support for vaccination, as well as a sharing of appropriate information, how they can be able to protect themselves from this yellow fever outbreak. The 5th is anthrax in Uganda. 12 new cases, including 1 confirmed and 11 suspected, but no deaths have been reported from Uganda since the last brief. And cumulatively, we have seen 30 cases, including 6 confirmed, 24 suspected, 2 deaths, giving us a 6.6% cumulative case fatality rate, have been reported from 3 districts in Uganda. The government there continues to actively conduct searches for any contacts and cases, including providing information to the populations that are affected, so as to limit the possibility of this outbreak spreading any further than it currently has. We are also supporting the government to train clinicians so that they can be able to handle whenever symptoms are expressed, even before laboratory confirmation, they can be able to handle such suspected cases in a professional way that limits any spread of anthrax in the country and beyond. The sixth is a multi-country Lassa fever outbreak. Since the last briefing, 93 new cases, including 5 confirmed and 88 suspected, but no new deaths have been reported from Nigeria. And this is a 52% decrease from the number of new cases that we reported here in the last brief. Cumulatively, though, 7,442 cases, including 955 confirmed and 6,487 suspected, with 194 deaths, giving us a case fatality rate of 2.6%, have been reported during this year from 7 of our member states here on the continent. We continue to support the affected countries with test kits and capacity building for management of Lassa fever. The 8th outbreak I would like to share is cholera. Since the last brief, 3,925 new cases and 58 deaths, giving us a case fatality rate for this week of 1.4%, have been reported from 7 of our member states. This is a very large increase from last time, and it is over a 100% increase when we look at the number of new cases that we saw during last week. The breakdown for this quite significant increase in the number of cases of cholera on the continent are as follows. Cameroon, 189 new cases, including 4 confirmed and 185 suspected, 7 new deaths, giving a 3.7% case fatality rate for this week in Cameroon. Malawi, 718, that is 718 new confirmed cases and 24 new deaths, giving us a case fatality rate of 2.9%. Mozambique, 561 new suspected cases, no deaths. Nigeria, 1,271 new suspected cases, 17 new deaths, giving us a case fatality rate for this week of 1.8% in Nigeria. Somalia, 1,035 new cases, including 33 confirmed and 1,002 suspected, 7 new deaths, giving us a case fatality rate of 0.7%. South Sudan, 2 new cases, including 1 confirmed and 1 suspected, and no deaths. DRC, 149 new suspected cases, 3 new deaths, giving us a case fatality rate of 2%. And when we look at the cumulative figures since the beginning of the year, 38,617 cases, including 3,911 that are confirmed, while 34,706 are suspected, 562 deaths, giving us a case fatality rate during this period of since the beginning of the year of 1.5% reported from 13 member states of the African Union. We are working with all affected countries to ensure that appropriate messages are being passed to the public for prevention, and those who are affected are getting the appropriate treatment. And then our health workers are getting the appropriate capacity building and tools for them to be able to work effectively. The final significant outbreak that I would like to report on is measles. Since the last briefing, 9,293 new cases with 676 new deaths have been reported, giving a case fatality rate for this week of 7.3%. These new cases have been reported from 6 of our member states, and this represents a 38% decrease in the number of new cases compared to the last update that we gave during last week. These 6 countries are Cameroon with 104 new cases, Central African Republic 37 new cases. DRC, 3,327 with 37 new deaths. Kenya, 6 new cases, no deaths. Senegal, 84 new cases, no deaths. And Zimbabwe, reporting 5,735 new cases and 639 new deaths. For measles, from the beginning of this year, we have cumulatively documented 178,465 cases, including 28,927 that are confirmed, while 149,000 are suspected, 2,218 deaths, giving us a cumulative case fatality rate of 1.2% reported from 24 of our member states here on the continent for this year. We continue to work with our member states in providing opportunities for increased vaccination as well as capacity building for our member states to ensure that there is optimal care being given to those who are affected. I would like to share 2 events that are coming up. Well, one event that is coming up and one announcement that has just been made recently, which is of significance to our work. On the 6th, 7th, and 8th of September, this is next week, we are hosting here in Addis Ababa a meeting of extended program of immunization managers from our African Union member states. And what we intend is for this meeting to contribute to the increase in vaccination rates at country level. We would like to take stock of the progress that we have made in COVID-19 vaccination. We would like to share lessons from different countries depending on the challenges they are facing, the successes that they have achieved, the methodologies they're using. And we would also like very much to formulate strategic shifts in priority actions so that we can be able to reach that 70% as soon as is possible. We are looking forward to the leadership of the continent being there to speak to our managers of the extended programs of immunization from African countries. The second is to really share our support with the agreement that Aspen and the Serum Institute of India signed yesterday, where we have 4 routine vaccines that are going to be manufactured by Aspen in South Africa for the African market. We are very supportive of these because it contributes directly to our ambition of manufacturing at least 60% of our human vaccines by 2040. It contributes to Africa's new public health order, where we are securing our own supplies. And it also very much is in line with the call by our heads of states since May that at least 30% of the human vaccines that we are using on the continent need to come from African manufacturers. So we congratulate Aspen and the Serum Institute of India for penning that particular agreement that we are looking forward to changing the way in which we access routine human vaccines here on the continent in the months and years to come. So, Wayne, this is what I wanted to share for today, and happy to take questions. Thank you.
Thank you very much, Ahmed. And we move straight into our question and answer section. The first question that we have today is from Judith Akolo, who is with the Kenya Broadcasting Corporation. My question is, she says, considering the rising number of monkeypox cases in the DRC, should the countries neighboring the DRC be worried? What about those that are trading with the DRC, where people and goods move across the borders? And finally, she says, what precautions should these countries take? For instance, what should they do in terms of preventive measures?
No, thank you. Thank you, Judith, for that. Whenever there is an outbreak of any disease that is transmissible, then every community and country globally is at risk. Not just the neighboring countries, but everybody is at risk because the way in which we travel these days and communicate has changed. And someone can be in Addis Ababa today, and by evening they are in Australia, the US, whatever, very far, not just a neighboring country. So we as Africa CDC are continue to recommend that all countries need to enhance their surveillance mechanisms. All countries need to build capacity of their health workers so that they are better prepared to identify the cases early. And all governments need to provide information to the members of the public so that they know what they should do in the event of exposure, and they know what they should do to prevent exposure. All countries on the continent, we are encouraging them to do this, not just those that are close to where a case may have been identified. In terms of trading, when it comes to specifically monkeypox, the method of transmission is such that you will not get monkeypox from goods. You get it from close contact by either someone who has monkeypox or an animal that may have the virus. So trading, so long as it is conducted within the protocols that have been established for monkeypox, trading should not be one of those risk items when it comes to, or risky conditions when it comes to monkeypox. What should governments do? We have issued at least twice now advisories to our governments on increasing early warning systems as capacity, ensuring that knowledge amongst health workers is high, knowledge amongst the members of the public is high, and wherever possible, being part of the global movement of trying to get vaccines onto the continent and also therapeutics onto the continent. Preparedness and response is a very key part of resilience for this continent, and we are encouraging our governments to ensure that their systems for preparedness and response when necessary have been strengthened, and Africa CDC remains very available to support any and all governments here on the continent of Africa. Thank you.
Coletta Wanjohi from FSN. What is the danger of us having delayed access to monkeypox vaccine supplies for Africa? Now that we see the numbers are increasing, is there a plan B apart from just making appeals to the developed countries?
No, thank you, Coletta. The danger of delaying access is that the numbers become larger, more communities and countries are affected, and therefore the risk will increase over time if we do not control monkeypox quickly. Apart from asking, there are three stages here when it comes to the vaccines that we need. One is the immediate stage where we want to immunize, particularly the front line workers and the affected communities now, so that we limit the spread of monkeypox. This you can only do with vaccines that are already been manufactured and are in existence. So this is where the asking and the negotiating comes in. The second is working with those institutions, companies that are in the process of expanding their production capacity so that we can be able to secure by purchase and other means doses that are yet to be manufactured. So this is the second different step that we can be able to take. Longer term is for us to build our own capacity, not just for manufacturing, but also for doing research and development of different types of vaccines and therapeutics and other countermeasure health products that we may be able to need. We are doing all three together because Africa has such a big gap when it comes to access to not just monkeypox vaccines, but all other types of health products that we need here on the continent. So we will continue to approach it from these three different angles until we get what Africa needs, what Africa deserves, what public health requires of all of us globally to ensure that the spread is limited. But you're absolutely correct. When the numbers are going up, it means that the tools are not being deployed in an equitable and optimal manner.
All right. We have a question from Sarah Jerving, who's with DevEx. She says there is an expectation that a famine might be declared in Somalia in the coming days. How could this declaration of a famine change the response? And I'm not quite sure which epidemic she's talking about, but perhaps it is to COVID-19 plus the others that you've mentioned.
No, thank you. Thank you, Sarah. Any situation that results in nutritional deficiencies will make the work of vaccination and successful control of any outbreak much more complex. And not just the COVID-19 pandemic, but any of those other outbreaks that we've talked about today. They will become worse if they exist, or if they are not there, then the risk is very high that something else, another outbreak may be able to occur in a community that has a severe nutritional deficiency, like what famine will be able to bring. What we are doing is every place on the continent of Africa where whether by nature or otherwise there are challenges in accessing good nutrition, we are working with the other agencies that are providing support for these other emergencies that are not health related, so that we go in tandem with them and provide the health part of the crisis. So in the situation of famine, for example, when distribution is being designed for food, then at the same time, we are going to be working with those who are working in the humanitarian sector to ensure that the health part is also covered well, so that when people are getting their food, they're also getting their medication, their health care, and their vaccines at the same time. But any declaration of famine is going to disrupt the work that we already started, and we are trying to limit the damage to that success that we're already achieving, particularly in communities that are facing severe nutritional deficiencies.
All right. Munyaradzi Makoni, who is a freelance journalist, says, what is the state of for long COVID in Africa? How is it impacting on public health? And are there any treatments and models of care that are working for long COVID in the African context?
No, thank you, Makoni, for that. State of long COVID, not well documented on the continent yet. We are working with selected countries who have good data from their health facilities to capture the burden of long COVID here on the continent. Unfortunately, many who have long COVID will not go back to the health facility, but they will sort of manage it from home, which makes it difficult for us to have a very clear picture of long COVID here on the continent. But we are working with those countries to get to understand what the burden of long COVID on the continent is. In terms of public health, it has a negative effect on the whole health system, both clinical and public, because anyone who has long COVID will require extended health care, will require extended care by the immediate family members, society, and government at large, someone like that will always be at risk of getting severely ill again. And this causes a strain on the health system and draws away resources from other aspects of healthcare that we continue to provide. So as we work with the countries to be able to understand what the situation is here on the continent, we will be preparing better for tracking who has long COVID and giving them the medical attention that they require over time. But at the moment, Makoni, we don't have a very good and clear picture of the burden of long COVID here in Africa. Thank you.
All right. I seem to have lost you there, Ahmed.
Yes, no, I'm done with that question. Sorry for connection problems.
All right.
And we can go on to the next.
Okay, we have two questions coming from Esther Nakazi. Now, Esther had her hand up previously, but she has now come through. All right. I was saying that our next questions are coming from Esther Nakazi, and Esther has come back. She was online previously, then wrote down her questions. Now she's back online. Esther, please go ahead with your question.
Thank you, Winnie, and thank you, Dr. Ahmad. My question is about surveillance capacity for wild polio in Africa. I just wonder what our capacities are for surveilling wild polio, and secondly, for the Saving Lives campaign that you're talking about, do the donors dictate the type of vaccines that we are rolling out in our countries? Because we have preferences, and I don't know if that happens, whether they ask us whether we need these doses and then they give us that, or they just say we are pushing these to you and that's what we roll out. Thank you.
Thank you, Esther. In terms of surveillance for wild polio in Africa, our surveillance is very good. And that is why we are picking up the cases early and then ensuring that it does not spread beyond the 1 or 2 cases, and now maximum of 6 that we have seen on the continent. So surveillance is very good. And we are confident that any case that will pop up in a community will be picked up quickly. We hope that does not happen beyond where we are now. And on top of that, we are continuing to build the capacity, particularly across borders, of the countries in the areas where we have seen wild polio, particularly in the southern part of Africa, the Horn of Africa. We are continuing to build the capacity of our different countries, particularly across borders, to be able to pick any case quickly. For the SLL program, indeed, for all our programs here at Africa CDC, we are very much implementing Africa's new public health order for action-oriented and respectful partnerships. No partner provides their preferences on what vaccine should be purchased. No partner provides their preferences for where the vaccines should go. No partner provides their preferences of what other countermeasure products we should be able to purchase to continue our vaccination campaigns here on the continent. That is solely the responsibility of Africa CDC and the Africa Union and our member states, and we work with them to achieve that. No partner dictates or provides preferences for any of the products that we use here on the continent. Thank you.
James Macharia Chege, who is with Reuters, says, I have a question on monkeypox in Africa. Is there anything that you can report about how the Africa CDC or countries on the continent are trying to procure vaccines or antivirals for use in Africa? Then he also asks about testing that is happening on the continent.
No, thank you, James. So you've covered the three big areas for any outbreak. Let me start with the testing. Newer products are coming onto the market, and as Africa CDC, we are working with the manufacturers to ensure that we test and then only procure those products that are giving us good results. So in terms of testing, there are several products available, and this is going to increase the laboratory diagnosis that we are having here on the continent. And we are doing this ourselves as Africa CDC here at the Africa Union. On therapeutics that are available, this has not been a very big challenge so far because we are using supportive treatment for those who are affected, those who are severely ill and need hospitalization. Again, we are using supportive treatment as their body picks up and then drives out the virus. In terms of the new therapeutic therapies that are coming onto the market, we are watching those, and as soon as they get approvals, then we engage with the countries the manufacturers that have the therapeutics. For vaccines, what we have done now is we have mapped the new generation vaccines that are in the pipeline. And we are discussing with all those companies that have products either very close to being made available to the public or those that have already been made available to the public, so that we have a strategic place using equity, because Africa is burdened by this for a very long time, so that we have a strategic place when the new products get manufactured, when the older ones, when the number of doses increase in terms of those that are already in existence, then we are in a safe place to be able to acquire those vaccines. At the moment, as I said, we have not yet gotten any because there are none to purchase. And those that have already been purchased, we are negotiating to see how soon they can be able to reach the continent. But we continue to work with all our friends and partners to ensure that at least some vaccines start coming to the continent in the coming weeks. When that situation changes, we will let you know, but a lot is happening in the background. A lot is happening in the background that is difficult to be able to share in a press briefing. Thank you.
All right, I think we have just about enough time for one last question from Judith Akolo. And she says, going by the disease outbreaks on the continent, most of the disease outbreaks are happening around the tropical rainforest region. And she points to the DRC, Cameroon, Central African Republic. And she says, do these have outbreaks of monkeypox, Ebola, yellow fever? Do these outbreaks have anything to do with the environmental degradation, especially the opening up of the rainforest areas for settlement and agriculture, as well as mining activities? If this is so, what should the member states do as part of their mitigation measures?
No, thank you. Thank you, Judith Akolo. The relationship between outbreaks, particularly emerging diseases and environmental degradation, is clear. We as human beings are going into caves, we are going into forests, we are going under the waters and destabilizing ecosystems that we were not supposed to destabilize. And in this way, we generate new pathogens to enter the human population. This connection is clear, and most of the outbreaks that we see are actually as a result of that interaction between the human population and parts of the environment that ideally they should not have been interacting with. What our countries can do, and when I say our countries now, I'm going beyond the African continent, what all countries should do is appreciate that link and then work towards limiting a disruption of the environment and the ecosystems that are not supposed to be interacted with by the human beings. In this way, we need policies that are going to encourage preservation of ecosystems and the environment, whether it is in the forest, whether it is in the mountains, whether it is underwater. We need policies that are going to protect those environments from being interfered with. And secondly, we need to improve the speed at which we respond to each and every outbreak so that it does not become a crisis. If it is 1-2 cases and we are able to control it, then it is much better for the human race if we control the outbreaks quickly. But the connection between the outbreaks and environmental degradation is very clear, and we need to work towards interacting less with parts of the ecosystem we are not supposed to interact with. And we also need to be preparing better so that we react fast and contain these outbreaks whenever they enter the human population. Thank you.
All right, that's the end of our question and answer section for today. Before we leave, however, I just want to raise the attention of journalists online to a press release that's just been issued by the Africa CDC, and it concerns the partnership between the Africa CDC and MasterCard Foundation in hosting 3 high-level events during the upcoming 77th UN General Assembly later this month. And the highlights that we can take from that press release are that the first one will be on the 18th of September, and it will be a high-level panel discussion under the theme, Advancing Africa's New Public Health Order, the Role of Partnerships. Then the second topic that will be discussed is there will be another high-level event co-hosted by the Republic of South Africa, and that will be held under the theme, Reimagining Health Workforce Development in Africa for Africa's Health Security, and that will be on the 19th. Then the last of the 3 events will be a high-level event under the theme, Africa's New Public Health Order, Rejuvenating the Global Health Security Agenda, and that will be on the 21st of September. So for the details of the times and venues and how to connect to those very important events, please do see the Africa CDC website, and that press release will be right there. But for now, it is time for us to conclude this press briefing for today. We will meet again next week on Thursday, as usual, at the same time. For now, bye-bye.
Remove sound and video.